In this third GI PowerPoint lecture, we're going to actually look at some other GI type of problems such as appendicitis, diverticulitis, peritonitis, irritable bowel disorder, and certain types of colon cancers. Appendicitis is actually the most common surgical emergency type of procedure that's done. It actually affects about 10% of all of the population. And the signs and symptoms that patients have when they present with appendicitis include abdominal pain that comes in waves. Pain is typically localized in the right lower quadrant at what's called McBurney's point. And this is about halfway between the umbilicus and the anterior spine of the ilium. This is considered a classic sign. The patient may also have rebound tenderness and pain, and with this there's relief of pain when pressure is put on McBurney's point, and then there's pain on release of that pressure, so that's called rebound tenderness. The patient may also have nausea, vomiting, a fever, on labs have an elevated white blood cell count, and unfortunately sometimes the patient will become pain-free, and a lot of times that is because the appendix actually ruptures, reducing the pressure that's within the abdominal cavity. So the mortality rate from appendicitis, especially in those patients that are over the age of 70, can get to be 20% or higher. If the patient especially perforates, that patient can have a lot of complications. This is just a diagram that depicts where the appendix is located. It really serves no great function other than to cause us a lot of misery, I guess. But it shows where in the bowel it's located at. Management of appendicitis includes that patient will be made NPO. They'll have an IV started and given fluids. They typically will try to make the diagnosis before giving a lot of pain meds. They don't want to mask the pain and the location of the pain till they determine exactly what's going on with that patient. And then, of course, they take the patient to surgery. Most patients are able to have a laparoscopic approach to an appendectomy done. With these patients, they may need a Penrose or Jackson-Pratt drain. Typically not, if it's just done by laparoscope. Patients that have the full incision, sometimes if they're not able to do it by the lap procedure, may end up coming back with drains and those types of things. And it kind of depends on if that patient has perforated or not perforated. Typically antibiotics are going to be given about 48 hours after surgery, and then also they'll be given antibiotics before surgery. Clafurin and Fortaz are two common antibiotics that are used for this disorder. Here's an example of an inflamed appendix that needs to be removed from the patient, or I should say at this point it was removed. Some complications, as we've already talked about, there's always that risk of peritonitis. That can occur if the appendix ruptures, and what it does is unfortunately spreads that whole infection throughout the abdominal cavity. So those patients will get high fevers, their abdomens will be very rigid, they'll have tachycardia, they may even look shocky where their blood pressure may go down, and it can be a very serious type of a thing depending on how long the patient has actually had the peritonitis. The patient may also have abscess formation, and with that they may have anorexia, chills, fever, and be very diaphoretic. And the patient can have a silent bowel or ileus where the bowel sounds are absent. And in that case, the patient's going to have nausea and vomiting, need an NG tube, and need IV fluids until that patient reestablishes some bowel function. Another type of disorder that we see in the GI system is diverticulosis, which is a small outpouching in the colon lining. You can have just diverticula without any inflammation. Once they become inflamed, then it becomes diverticulitis. With the patient that has diverticulitis, there's always that risk of infection and inflammation, and typically those patients will have nausea and vomiting, feel very bloated, crampy. They may have a low-grade fever, and the most common area of the bowel that these are found is actually in the sigmoid colon, and that's about 90% of where you see the diverticulitis occur. Typically the patient may have crampy, kind of left lower quadrant abdominal pain. when they have this diverticulitis flare-up, and they can be quite miserable. One of the major factors that contributes to this particular disorder is a low fiber diet and lots of refined foods in the diet. That's why it's important to tell our patients it's important that they include lots of high fiber things in their diet, lots of fruits, vegetables, and high fiber grains and things like that. So unfortunately, what can actually happen is that the bowel mucosa can herniate through those defects in the colon wall, and then that muscle can thicken and hypertrophy, and the patient can actually get a narrowed bowel lumen because of all this. Many times these patients will also suffer from an irritable bowel syndrome along with their diverticulitis. So complications, worst case scenario in this kind of a situation is that the patient could actually hemorrhage, have a bowel obstruction, or develop a fistula. Management of diverticular disease, first of all, it's going to be typically diagnosed with a CT scan, barium enema, or sigmoidoscopy. And then once that patient has developed diverticulitis, the bowel needs to be rested. So that patient is put on NPO status or clear liquids, given IV fluids for hydration, antibiotics, analgesics, and anticholinergics to help with the spasms in the bowel. The patient may have to go to surgery depending on the extent of the diverticulosis, and they may need a temporary colostomy if it's also severe. So once again, common antibiotics used for this particular disease, Flagyl, Cipro, sometimes Bactrim. Some teaching to do with the patient that has diverticulosis is to try to prevent constipation, adequate fluid and fiber, keep the fat low in the diet, use stool softeners, exercise daily, and foods such as nuts, seeds, and corn can become actually trapped in the diverticula and trigger inflammation. So some patients are advised to avoid eating these types of foods. So it's kind of a controversial point. Some research says yes, this can cause an inflammation, and some poor sequela, and others say not so much. So depends on the source that you actually look at. We touched earlier a little bit on one complication of appendicitis being peritonitis. Peritonitis can actually occur from other things, not just appendicitis. It's considered to be a generalized inflammation of the peritoneum, and it can result from any bacterial or intestinal contents in the peritoneal cavity. It can occur spontaneous, or it can be the result of like trauma, ruptured appendix, perforated ulcer, perforated intestine, the patient who has peritoneal dialysis, or it could actually be an extension of another systemic infection that the patient has that has traveled throughout the body, such as the patient maybe started with a urinary tract infection and then ended up with serious complications such as peritonitis. So the list for you some different kinds of causes of peritonitis. Another one we didn't talk about is pelvic inflammatory disease. That's another common cause of peritonitis. So diagnosis is going to be based upon the symptoms the patient presents with, lab work, which is going to show an elevated WBC count, and they'll actually do a culture of the peritoneal fluid, which can show an elevated bacterial count. Classic symptoms of peritonitis: the patient presents with abdominal pain, rebound tenderness, guarding, abdomen is very rigid, may also be distended. Patient may have a paralytic ileus where you're not hearing any bowel sounds, elevated WBCs, nausea, vomiting, and the patient will look very shocky. Typically, patients with a severe case of peritonitis will need to be back in an intensive care setting, being monitored and watched for shock. Management is going to consider fluid resuscitation, antibiotics. Patient might have to go to surgery to try to remove a lot of the infection that's already attacked some of the internal organs. Close eye on vital signs and I&O, fluid and electrolyte replacement, and the patient's going to be put on typically broad spectrum types of antibiotics. Typically, the patient will also have an NG tube, be on bed rest. Semi-Fowler's is a little bit more comfortable of a position. It takes some of the pressure off the abdomen. and the patient is encouraged to do deep breathing exercises. And since many times they're going to be NPO for several days while they manage the peritonitis, the patient may require TPN and lipids to be able to give them some nutrition while they're under management. The overall mortality rate from peritonitis is about 40% of patients will die from this, so it just kind of shows how this can be a very, very serious type of an illness. For young people and patients where they catch that peritonitis early on, the mortality rate's less than 10%. So it's very important that as nurses we pick up on early signs and symptoms that our patients may have of peritonitis, because they're going to do much better if we can get them treated early on rather than until that infection has had a chance to settle in the abdominal cavity. Other things the patients may need are that because of the massive shifts of fluid within the gut, and they will have hypovolemic and shock, so they may need to have colloid replacement to help bring back management of their vascular system and those types of things. The next disorder we're going to talk about is inflammatory bowel disease. There are actually two different types of diseases that fall into this category. Crohn's disease is one of them, and the second one is ulcerative colitis. So we're going to talk a little bit about both of those. The next few slides are going to kind of compare and contrast the differences between those two. And actually in your book there's a great table that looks at the differences between those, so make sure that you take a look at that. Crohn's disease is considered a chronic episodic inflammatory condition of the GI tract, tends to affect the entire wall of the involved bowel, and there's areas of inflammation with areas of normal lining in between typically. This next slide shows actually what the typical symptoms are and the look of a Crohn's disease type of bowel. So actually what happens here is there's actually a cobblestone kind of appearance of the bowel that's surrounded by ulcerations and fissures. So typically that small bowel will get affected in patchy areas. So you can see kind of that cobblestone look that's there. Patients that have Crohn's disease are at increased risk for colon cancer just due to the history and the disorder that goes along with this disease. Classic symptoms that the patient will come in with are diarrhea and abdominal pain. The diarrhea may have mucus with it. They may also have fat in the stool, which is what steatorrhea is, and they have poor absorption of all their fat-soluble vitamins, which are your A, D, E, and K. And the patient will typically have colicky, severe abdominal pain that will occur many times after eating, that's diffuse or localized in more of the right lower quadrant. Inflammatory bowel disease, when we look at ulcerative colitis, you can see how this bowel looks different than the one from Crohn's. This is a disease more of the colon and large intestines, whereas Crohn's was with more of the small intestine. This one includes ulcers and open sores also. Usually this one affects the rectum and sigmoid colon, and the patient is at huge risk for perforation and massive hemorrhage in this area. Usually with this one, the large bowel is going to be affected in more of a continuous pattern, whereas with Crohn's it was more of a patchy kind of a look. So the classic symptoms with ulcerative colitis is that the patient presents with bloody diarrhea. They may have anywhere from 5 to 30 bloody diarrhea stools per day. Patient will have abdominal pain, fatigue, anemia due to losing all of that blood through diarrhea, and the patient will have left-sided abdominal pain that feels very colicky and those types of things. It typically affects about 500,000 people in the United States each year, and the age at onset is typically a younger population. Between 15 and 35 we see it most commonly diagnosed, and then there's another age bracket between 50 and 70 where you see once again patients get typically diagnosed with this disease. Management of inflammatory bowel disease is going to include to do labs to watch, keep a close eye on anemia, so keep a close eye on the hemoglobin and hematocrit of those patients, to look at the SED rate, for infection, see if it's elevated. Check albumin levels. It typically will be decreased due to the malabsorption and protein loss with the diarrhea in these disorders. Check liver function tests. If there's liver involvement where the liver sclerosed due to other problems with the bowel, you may see elevations in the liver function test, those types of things. And then also do barium enema, ultrasound, and medications to treat these. There's a medication review in your textbook that reviews all sorts of medications that patients with inflammatory bowel disease are typically put on. One common med is actually asulfidine, and this is an anti-inflammatory med that works on the intestinal mucosa. However, there is a risk for kidney damage with this drug, so check BUN and creatinine carefully with it. Asacol, ASACOL, is another drug that's commonly used, which also has anti-inflammatory effects on the intestine, but a little bit less side effects. And then the third med that's very commonly used are corticosteroids, such as salumedrol and prednisone, just for those anti-inflammatory properties. Some patients will require surgical management if medication is not doing the job, so they'll actually remove the diseased part of the bowel. They may have a segmental resection with a reanastomosis, and so these patients commonly will have an ileostomy. Some patients actually will be able to have just a temporary ileostomy for maybe 2 or 3 months while the bowel heals, and then what they can do is actually bring that ileum bowel, make a anal anastomosis with an ileal pouch, and then the patient would have more of a normal type of bowel movement function. So some patients, they'll be able to do this type of a thing. Other things to manage would be diet and fluids. Typically they're going to be put on high-calorie, well-balanced diets. Try to avoid those foods that they know tends to set their disease off. Some patients will need dairy products limited if calcium or if dairy products are the source of the problem. Because they're losing so many of their electrolytes and vitamins and minerals through their stooling, they'll probably need to take multivitamin daily supplements and increase their fluids. Elimination to help with those kinds of issues and the diarrhea. They can take medications as prescribed, comfort measures for the rectal area, and check with the physician before they would start any anti-diarrheal meds or any bulk-forming laxatives or anything like that. So sometimes they're actually recommended to increase dietary fiber, which kind of sounds like that would be a contradiction, but increasing dietary fiber can actually decrease the diarrhea and rectal symptoms because it adds more bulk to the stool. So some patients may actually be NPO for quite a while it heals with TPN and lipids just to kind of heal the gut. Rest and coping is important for these patients, so make sure that they are getting enough sleep and try to get them into support groups also. That's very helpful. As far as health maintenance, make sure that they know when to contact the physician or healthcare provider to note when the abdominal pain and diarrhea requires an office or hospital visit, and whenever they're having changes in stool characters or unusual discharge, they need to make sure that they're letting their physician know if it's something that is unusual for them. Fever is rare with ulcerative colitis, but you may actually see this as a part of Crohn's disease. So it's just important that patients do regular follow-up visits with their healthcare provider. Bowel obstructions is the next disorder that we're going to talk about. Patients may have mechanical or non-mechanical. Mechanical examples of that would be intussusception, which we're going to see a picture of that, where the bowel actually telescopes in upon itself, which obstructs the bowel. A volvulus is actually a twisting of the bowel, and non-mechanical types of obstructions would be paralytic ileus, which we talked about with peritonitis, neurogenic bowel problems, or a foreign body in the bowel or something like that. So patients that have those neurogenic bowel obstructions, it could be from somebody that has an impairment like multiple sclerosis, Parkinson's disease, something like that, where there's actually neuro problem going along with the bowel issue. This just shows some examples of those. As you can see, intussusception is in the upper left-hand corner where the bowel telescopes in among itself. A lot of times this does require surgery to fix this problem. Same with a volvulus, where the bowel can twist and then become necrotic. And then the other one just shows example of a hernia where the bowel actually loops down through an opening in the abdominal cavity, and it can actually become necrotic this way too. Symptoms of patients with obstructions are going to include pain, nausea and vomiting, abdominal distension. Bowel sounds, of course, will be decreased or may not be present at all. Patient may have fever, and the patient will have altered lab values. It can show fluid and electrolyte imbalances, particularly decreased potassium and chloride due to patient if they have a lot of vomiting going on. The CT scan can actually show distended loops of the intestine, and if that patient has fluid and gas trapped in the bowel, the CT scan will pick up on those changes. Patients typically will have a lot of colicky pain with these particular types of obstructions, and with that nausea and vomiting, sometimes the vomitous material may actually contain fecal matter because of the obstruction, especially if that patient has a low or a distal GI obstruction and those types of things. Of course, what we worry about is that patient having a necrotic area of the bowel, and if that's the case, the patient's going to have to go to surgery and have that removed, and then we need to watch for peritonitis and those types of things. There's always that risk of gangrene, which can lead to septic shock. Other management issues with obstruction is to correct the fluid and electrolyte imbalances, correct acid-base imbalances. We talked about surgery already, and the patients more than likely will need an NG to decompress the stomach before surgery. The other thing that needs to be done before surgery is the patient will more than likely be hypokalemic, so you need to take care of that low potassium problem that patient will have. Many times the patients are going to be in metabolic alkalosis due to that loss of hydrochloric acid through the stomach and through vomiting and all those types of things. So that'll need to be also reversed before that patient goes to surgery. Nursing care for the patient that has intestinal obstruction is going to include a close eye on vital signs, urine output, NG output. Watch to make sure that the patient is balanced with I&O, considering they're going to be getting a lot of IV fluids. Check to make sure that that patient is not third spacing, and if they are, it's important to keep a close eye on that. Third spacing is where there's actually fluids that are accumulating within the abdominal cavity and lots of edema involved. So it's important to measure the abdominal girth every 2 to 4 hours on these patients. Keep the head of the bed elevated. That will help to take the pressure off the abdomen, and it's usually just a more comfortable position for the patient. And assess for pain and provide pain medications. Analgesics may be used very sparingly until they come up with a definitive diagnosis for this patient, so that can be a challenging type of a thing. And just lots of support to the family regarding anxiety. Colorectal cancer is a disorder that's the third most common cancer in the United States. It causes about 56,000 deaths per year. However, with early diagnosis and treatment, the 5-year survival rate is about 90%. The unfortunate thing is probably only about 1/3 of all cases get diagnosed early. So a lot of times patients present for care when actually it's quite extended in those types of things. Many colorectal cancers start as an adenocarcinoma that began as a adenoma type of a polyp. Colorectal cancer typically grows slowly. The patient unfortunately could have had 5 to 15 years of colorectal cancer growth before they actually start to have symptoms. So typical symptoms a patient will present with are either diarrhea or constipation, rectal bleeding, pain, anorexia, weight loss, and the patient may actually, if it's been quite extensive, may have a palpable abdominal or rectal mass. The risk factors are those patients that are over 50, that have a history of polyps, that have a family history of colon cancer, patients also that have a history of inflammatory bowel disease, increases the risk of colon cancer, and those patients that tend to eat a high-fat, low-fiber type of a diet. So some intervention methods would be to encourage our patients to get sigmoidoscopies after age of 50, same with colonoscopies, check stool for occult blood 50 and over, get digital rectal exams starting at about age 40, and to try and increase fiber, fluids, and decreased refined foods as far as diet modifications go. This just shows the typical prevalence of where colorectal cancer is typically located. You can see the different areas of the bowel that are most commonly affected by this type of cancer. Surgery is going to be the treatment of choice for this type of cancer, and the surgery the patient has is going to depend on the location and extent of the tumor. Typically, if the tumor is also involves the lymph nodes, then those are going to need to be removed. So the tumor can either be in the ascending, transverse, or descending colon, and typically the surgeon will remove the cancerous part of the bowel and then do an end-to-end anastomosis. So it just depends on what area of the bowel is actually affected. Those patients will then end up with a colostomy, and it's important as nurses that we know the important types of things to look for. So in your book there, you can see some pages to look at for patients that are having this type of a procedure done. And for tumors of the rectum, patients may have colostomies, they may have peritoneal drains, and patients may end up with abdominal peritoneal resection. So you can see pictures of that in this particular slide. Pre-op assessments for patients undergoing a colostomy would be including bowel prep, oral antibiotics or IV antibiotics, and then post-op teaching would include ostomy care, care of the wound, NG tube maintenance, pain management, and trying to keep the lungs inflated. So patient using incentive spirometer and coughing and deep breathing exercises. Also, it's important to keep a close eye on fluid and electrolytes, peristalsis action, make sure the patient is getting bowel sounds back, that they don't have respiratory complications, and to follow up teaching. The patient may also require chemotherapy and radiation as part of their treatment in addition to surgery. So it's important to make sure that the patient knows what follow-up care is actually needed once they're done with their surgical procedure. So that pretty much sums up the first three parts of the GI lecture, and we'll be moving on to nursing management of a patient with gallbladder, pancreas, and liver problems next.